This is The Rounds Table. Right, welcome back. Another solo episode. This is related to a drug called Lorundrostat. You've probably never heard of it, but you probably will be hearing about it more. This was published in the New England Journal of Medicine in 2025, and the article is entitled Lorundrostat, Efficacy and Safety in Patients with Uncontrolled Hypertension. I think we all know how common hypertension is. And there's a subset of patients that, despite multiple medications at high doses, were still not able to effectively control their blood pressure. Most often, treatment-resistant hypertension is defined as a blood pressure that remains above target despite taking 3 antihypertensive agents of different classes, including a diuretic at max tolerated doses. Pearl, I think diuretics are probably the most effective medication for reducing somebody's systolic blood pressure. So often, the 3 drugs in question include a calcium channel blocker, an ACE or ARB, and the good old-fashioned diuretic. As I reviewed this trial, it made me realize that aldosterone dysregulation is a major driver of persistent blood pressure elevation in these patients. So, quick reminder, aldosterone promotes sodium retention. This leads to volume expansion, as well as vascular remodeling, all of which contribute to ongoing high blood pressure and end organ damage. It's probably unsurprising that a common fourth-line agent for the management of hypertension is a drug like spironolactone because of its effects on aldosterone. So enter this new medication called Lorundrostat. It's a highly selective aldosterone synthase inhibitor. So the idea here is that it should effectively be really good at targeting aldosterone biosynthesis, said simply, lowering aldosterone levels. And the fact that it's specific to aldosterone production, the hope is that it will spare other adrenal steroid pathways. It might have lower side effects than, say, a drug like spironolactone, and maybe even better efficacy. So enter this phase 2 trial. So how did they do this study? It was industry funded, multi-center, double-blind, placebo-controlled, and they included adults who were receiving 2 to 5 antihypertensives, and despite this, they still had a blood pressure above 140 on 90. Some key exclusion criteria: they excluded patients with a GFR less than 45, patients with a potassium of 5 or greater, or with a sodium of less than 135. So among these eligible patients, the first step before randomization was this single blind run-in phase. It lasted 3 weeks, and all of the patients were started on a standardized hypertension regimen. The regimen included olmesartan 40 milligrams daily, indapamide 2.5 milligrams, or hydrochlorothiazide 25 milligrams daily, plus or minus amlodipine 10 milligrams daily. After this 3-week period where they were on this standardized regimen, those with 24-hour ambulatory blood pressure above 130 on 80, they were then randomized. So it's a subset of patients. The intervention, Lorundrostat 50 milligrams daily at a standard dose, or up titration to 100 milligrams daily. They called that the adjusted dose group, and the comparator was placebo. The outcome here was a 24-hour change in blood pressure from baseline to week 12. All right, so who did they include? What did the patients look like? Well, there were 285 patients randomized. Average age was 60 years. Half were Black, 60% were men. The average BMI was 32, and 40% had type 2 diabetes. I know what you're thinking. I wonder how many patients were prescribed semaglutide or an SGLT2. I don't see those data reported here in this study, so I can't answer that question. And yes, it will be an important limitation. All right, so their primary outcome, and again, that was the change in systolic blood pressure by 12 weeks. So in the 50 milligram daily dose group, it reduced by 15 millimeters of mercury. In the adjusted group, essentially the same at minus 14. And in the placebo group, minus 7. Nice reminder that the placebo can be very powerful. In terms of side effects, hyperkalemia occurred in 5% of those on the 50 milligram dose, 7% in the dose adjusted group, and 0% with placebo. So there you have it. That's the study. What are the limitations? 12 weeks is way too short, okay? That is the clear elephant in the room. When patients are on medications for high blood pressure, often they're on these drugs lifelong. So 12 weeks is just way too short. When your study is that short, you're probably also underestimating the adverse events and risks here. Fortunately, there is a longer ongoing trial. That's going to be the phase 3 trial, which should give us more information on the safety, the efficacy, and other important aspects of this medication. Like, for example, sure, maybe if you stay on it for 12 weeks, you see a really good reduction in your systolic blood pressure. But if the adherence is lousy by 1 year, then that magnitude, that big reduction in systolic blood pressure, it might be not so informative. Also, anyone who's following closely SGLT2s and GLP-1s and who's prescribing them or has reviewed data from the trials of these medications will know that both classes of medications help to lower somebody's blood pressure. With SGLT2s, on average, if somebody has diabetes, it reduces their blood pressure by 5 millimeters of mercury. If they don't have diabetes, it's lower, maybe 2 to 3 points. Whereas with GLP-1 analogs, they have a really impressive effect on people's blood pressure. Often it's like almost 10 millimeters of mercury reduction in systolic blood pressure. So I would have loved to have seen how often these drugs were being used. As more time passes, I kind of think that perhaps in the adult who has both obesity and treatment-resistant hypertension, GLP-1 might be the right answer. And maybe we'll see lower rates of treatment-resistant hypertension in this patient population. But of course, that's me speculating. Let's see what the data shows in a few years' time. I think that's probably it for this medication and this trial. Would love to hear people's feedback. What did we get wrong? In terms of good stuff, just an ongoing plug for Trial Files. Trial Files is a great way to stay up to date on randomized trials related to general internal medicine, such as the study you heard about today. It's pushed out once monthly, sometimes once every 2 weeks as a newsletter, generated and summarized by a large language model. All right, that's it for this episode. Take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.